where the size of the cancer can be measured. This is they call it positron, yeah, positron, where the positron hit each other, that we split up. They measure that must be 160 degrees, then only they calculate or detect that. If not, they just erase it. So that's why we can see the image like this. This is a PET CT. Yeah? The image is something like black dot only. Yeah, that's why it's not nice and hard to see the area. That's why they combine with CT scan so that we can get better image like that. Okay, here PET image, here CT image. They combine together. You see, you can see very nice CT scan face here, mandible and head over there, and we can see that the same area, the same level. Yeah. Then combined with that, we can see very nice two images combined, then they can detect. The analogy is very simple. If you can see the cloud, that we don't know the location. Once we use a sensor or GPS, then we can see where the cloud is. That's something that we can compare. Yeah. So this is a technology or trend that people must have in at the hospital. Here in Malaysia, we got various places. For example, UPM, they have that. Yeah, PET CT center. Okay. This is the image from CT, and from when you look like this we call it as a coronal plane. Yeah, we cut slight way, but this is not the originally can get this image. This is not MRI. MRI is we can get any plane of the body, but for PET CT we normally do axial. Then this image is like reconstruction using computer. They process it and display like this. Yeah. This is another a type of CT scan and PET, yeah, together. I just skip that. So radiation dose, I think if you learn that environments and something that units easily, I just simplify in one slide here. Okay, radiation exposed, then we call it as a absorbed dose, unit gray. This is in air. Okay, but once they imparted in the human body, we call it absorbed dose. Yeah, gray. The unit is gray. If karma is different unit, now we same unit, but now we use gray, the term, so that easy for you to understand when I explain later on. Okay. If we use X-ray, because the X-ray factor, weighting factor is 1, then we use this different unit already. Yeah, we call it equivalent dose. The equivalent means we already take into account the X-rays power. Okay, then we call it as a sievert. When we discuss later, millisievert is something that we already take account of the radiation dose in our term, in our unit. Then when we compare to the tissue factor, because our body got various absorptions, attenuation of radiations, then we have that kind of let's say breast, gonad. They have a different absorption and different hazard or effect. Yeah? So that we call it the whole body equal to 1, 2. Yeah, to 1. So the unit now changed to millisievert. One I mentioned millisievert mean we call it effective dose. This is where we calculate the hazard of the patients. Yeah, like annual limit of radiation to workers is about 50 millisievert a year. Yeah, annually. So this we're talking about the effect of radiation dose to the human body, okay, by X-rays. Yeah, then that's what I prefer if you understand this, or maybe you already know. This is like a review. Then if we measure or study the whole population in that group, for example, my thesis on CT scan, then I can say it as like collective dose, yeah. Dose from CT scan in Malaysian population, for example, like man-sievert, something like that. So we talk about that, okay. Different unit, different representations, yeah. If we compare that CT scan and now X-rays, what the time now? 9:40. I'm going to I try to make it a little bit faster. Yeah. And CT scan, because the X-rays going around the body, then the radiation dose is quite high. Compared to conventional, we have maybe one or two projection for one area, so that a very little. Yeah. Compared, we going to see the table later how much the dose compared to general radiography. This is where the X-ray CT scan, and this is an X-ray. See the black there, that's a dose profile there, and lower here a little bit low because absorbed by certain area in human body here, or we call it phantom there. But for CT scan, throughout the circle, that's the radiations absorbed by that structure or object. Definition, I mean terminology they use in CT scan. Have you heard that CTDI? Have you heard CTDI weightage, CTDI volume, and DLP? These three, if you cannot remember everything, many term we use here. CTDI is something introduced previously. So now they have weightage. This one also used for phantom measurement. Now we have CTDI volume that normally used in a CT scan, and another one is a dose length product. This one produced when we do an examination, and DLP just how far that we scan the patients. So these two combination, then we can get the CT scan from dose from CT scan. Sorry. Yeah, this is something that profile we cannot, even though we just scan one slice, there is a radiation absorbed by neighboring structure over there. Yeah. So this is about CT scan profile, dose profile. Okay. If you can see that how we can get dose, we just move this tail and put it at the top here. Then this is the value of CTDI. Yeah. So meaning that even though the profile somewhere there, but we also take into account neighboring absorbed dose there, so that we can calculate or can say that this is the CTDI of the one slice of the CT scan. Okay, that's something that we need to understand about CT scan, how we calculate the dose from CT scan. Okay, as a CT scan, we have an axial mode. If just take one by one slice, or we just move the patient throughout the gantry and the tube move around, then we can get the all information. After that, computer do their work and produce or display the image. Okay, this is all the pitch definition. I already mentioned that. And CTDI, this is CTDI one slice. Remember that I mentioned that. And here the dose length product, how far that we expose patient to the radiations. So here we can say that from thorax up to pelvis, yeah, the whole abdomen and thorax already irradiated by CT scan in these examinations. We use ionization chamber to measure that. Okay. This is the ionization chambers. This is a gantry. We got phantom there. Just want to, before I forget, we measure this dose with this phantom. Just want to know the characteristic of that CT scan, how much the dose from that unit. So we measure this. Okay. When want to measure the patient dose, we calculate or we take note how far it goes. Yeah. That's we call it dose length product. After that, we calculate. Yeah. We multiply these two unit or two measurement, then we can get the full amount of radiation dose of the patient. But still not complete yet. We have another point to be considered before we can say that this is a radiation dose from CT scan. Okay. I think you cannot see here. This is something that I got it from monitor of the CT scan, the DLP and CTDI, yeah, or the reading there. We can see if we look at the monitor. Okay. And this is the table. I can already told you that this is something that we compare chest X-ray effective dose. Yeah, remember that millisievert only 0.02. However, equivalent number of chest X-ray only 1. Okay, if we take X-ray for medical checkup, for example, today or coughing, then doctor requests for X-ray. We only exposed to 0.02 millisievert. Okay, that for one X-ray. If you have chest X-ray here, I want to compare with chest CT scan. If we take one CT scan, effective dose about 3. 3 compared to 0.02, about 150 times. Meaning that if you take one chest CT scan, equivalent to you take 150 chest X-ray. Can you imagine that? 1 year, how many times you take X-ray, chest X-ray? But this one is 150 times. So that's, we need to compare about the radiation dose from one chest X-ray compared to CT scan. 150, that's a lot, okay? So far, so good? Any response? You can unmute your your mic if you want to say something. Okay, I continue with this.
Ya, I think continue dulu lah Prof. Nanti kita tanya soalan. Nanti kan tersangkut
Senang.
lah.
Okay, all right. Now this is as PET CT radiations. Yeah. We got, I already mentioned that briefly. So we got two actually system. One for PET using radiations and camera. Yeah. And another one is a external CT scan. Okay. Here we use FDG. Yeah, that's a isotope with the isotope used in that PET. Yeah. After that, they calculate that in the hot lab. Yeah, they measure how much they're going to give the patients. Yeah, this about 1.47 millisievert. Yeah, dose from the patients, and per gray here. I mean, this is something that if we use a PET CT and we have CT scan also here, then we can combine that if we use PET CT. Yeah. Because in the isotope we use megabecquerel. Yeah, megabecquerel dose. Okay. This is a figure of radiation source and doses. Yeah. So I don't know here. I can see very small there, but you see the red one is something about background radiation. Yeah, radon. I think environment always here. Blue, computer tomography. See, and first environmental radiation, cosmic radon, and we got CT scan. The rest is Nuclear medicine, yeah, quite high too, like PET, yeah, also quite high. And the rest is something that general radiography or other examination. Here is like industrial um, radiation dose actually, yeah. This is a small portion of that, yeah. If we want to compare here, human exposure to radiation dose, one CT about to test about 5 millisievert. We're talking about millisievert now. What is millisievert? The first gray, then sievert, and millisievert. Yeah? When we take into account the human body reaction to the dose, that we call it millisievert. Okay, so CT scan about 5, cosmic radiation around 2. Yeah, and this one pilot, yeah, airline pilot normally exposed to radiation a lot because cosmic radiations, and neutral background, yeah, 1.5. Australia something. I got this from Apansa. If you search ARPANSA, that's a body, authority body that in Australia monitoring all these kind of radiation, hazard, environmental, everything. And it's also produce license for people who going to practice X-ray or something like that. I need to get that also if I want to teach X-ray in my class. You know, I got one license also from them. So one chest X-ray here got different in Australia, 0.06. Just now I mentioned about 0.02. You see, different technology, different machine, they produce difference. Yeah. For example, if they have a very high technology, good detector, good X-ray tube that produce X-ray, we can get a better dose reductions. Okay. IEA always suggests that we have to use justification, optimization, and knowledge, yeah, to get this when we deal with CT scan. Yeah, optimization means what? We can try to use practical exposure parameters, KVP, MAS, and DLP, all these things, yeah, to get good image. Justifications, decision made by doctors, either this case need X-ray or not. Like kids or pediatric, they try to avoid more CT scan, yeah. They don't simply request CT scan for pediatric until 16 years old, yeah. That we call it justification. Or maybe they need X-ray, CT scan, examination to show something. Then only they proceed. Yeah, and this knowledge, this is something that controversial part where we need to know the workers need to know all this information. Yeah, and understand how much the radiation does from the CT scan. Then only we appreciate how to produce that image in that particular optimization way, so that we not really expose radiation to the patient too much or over the limits that we supposed to expose. Yeah, good practice we call it. And this is another graph that showing that blue is computer tomography. This one normally in a medical, yeah, in medical area. Yeah, as this one is a red fluoroscopy and general radiography. Fluoroscopy, another source of quite high radiation because they keep on the X-rays, yeah, to see the image whether you do a catheterization to see the heart or whatever, to check the contrast inside the body. So all this kind of information with a different kind of system or modality, we call it. And as overall, CT scans still contribute about 60 to 70% in the medical examination of the whole modality. Okay. And I think either you can see or not this table, quite there's a little bit of comparison, yeah, for the dose, we call it dose length product. The unit is milligray centimeter. Remember that we use that centimeter to measure the length, and out of that we can say that this is the dose length product. After that we convert this to millisievert. Why we need to convert that? Because we need to compare this CT scan dose with breast dose and other examination. That's why we need to compare that. I mean to convert. And before I forget, this all measurement, these numbers actually not done to the patient. We just measure from the phantom, not real patient. So this is something totally different compared to the radiation dose that we have from the patient in general radiography. Must remember that. Okay, CT scan dose always we compare to the phantom. Okay, it's not real dose from patients. Okay, so this is the numbers that we need to multiply if you want to convert to millisievert. Okay, you see the unit millisievert, milligray, and centimeter. Okay, so from there we can get millisievert unit. Okay. Another
slide Prof bergerak.
Yeah, last slide.
Slide Prof tak bergerak. Baru gerak.
Gerak. Delay ya.
Tadi ni Prof tunjuk pie chart. Okay, continue.
Okay. You can see here table. This is the another organization. For example, we have American, European, Australia radiation dose. We got it index here, so that they use this figure to multiply with the LP. A little bit complicated, yeah. If we look CT scan dose compared to general radiography. General radiography very simple. We use ionization chamber, put behind there, or now we got DAP, yeah, dose area product. Straight away we have a dose area product. After the collimator X-ray tube there, we expose, we can get the reading straight away with X-ray general radiography. But for computer tomography, we got display that, but that reading is just compared to the phantom, yeah, not the to pass through the patients. Okay, that's a slightly difference. I got this information from Alphansa, ARPANSA. If you want to know more about CT scan or positron, they discuss very detailed there. So those who interested to, okay. So we got CT scan and PET component, PET CT recorded, and this is the measurement, okay, combined two. Yeah, we have CTDI in milligray and DLP in millisievert, milligray centimeter. So they have another column supposed to be here, millisievert, where this number multiplied by the factor just now to get millisievert. Okay, now we can see something locally. Yeah, I got it from Sabri and Wong. Yeah, 2019.
Slide nak ubah je, Prof.
Sorry,
Slide masih table lagi.
Now
Belum lagi, masih 3 category of EIA sample.
Sorry.
I think Prof nak tunjuk yang pie chart tu kan?
No, I'm talking about Malaysia now. Slide Malaysia with the blue and yellow letter.
Okay. Belum, lambat lagi, jauh lagi.
Oh ya.
Sekarang baru slide 31. I think slide Prof perlu 38 kan?
My slide, yeah, 38, number 38.
Sekarang 31 on screen.
Why is very slow there?
Tak tahulah, mungkin ada.
Do you get 38?
Sebab saya ada terima yang ni, so I think Prof cuba share on the slide 38 kan, which is Malaysia perspective kan.
Yeah, average effective dose for whole body PET CT around 14.82. Yeah, and DLP. And another term that they use, SSDE. I mean, size-specific dose equivalence. That's something. How to move the. Somebody suggests that we can move something.
My slide is a Malaysia one.
Okay.
I think some certain page or network kot mungkin ada masalah sikit.
Yeah.
Nak download sebagainya lah kan. So I think
In,
one of the way is dalam yang WhatsApp hantar by admin kepada buat bicara group tu, I think can help you to open that cepat sikit kot from your handphone.
You just can listen my voice, then you can on the slide to
mungkin probably have mentioned slide number berapa lah just to help us.
Okay, yeah. Slide number 38 now. And this is a few things that we need to discuss, you know, that I found from my study those days and are still valid for Asian here, like Philippines, Indonesian, Thailand, because we have Vietnam, yeah, because we have a same size, not like European or Arab country, Middle East, yeah, they all have a bigger size than us. So in that situation, we can say that in Malaysia, we we already exposed to higher dose compared to European practice there. Why? Because our body a little bit smaller, and they use the same parameters, factors, KVP, MES, those days, yeah, because before that, people not really aware about this. They just use a preset protocol. They just expose that. They got image. So meaning that we expose extra, we get extra dose compared to other people in Europe. So once we realize this, so we reduce the dose. Let's say in European, they use 120, we might use 100 kVp. They use about 400 MES, we just use about 300 MES. We reduce the dose to get the same quality of image. Yeah, so that's still we can improve a lot with this new approach. We call it as SSDE, size specific dose equivalence, where we have to calculate the size of our body, then how much exposure that we need to use. And another things that they use automated sensor so that we can reduce and increase the radiation dose to the patient. That's a better approach, and use automatic approach. Yeah. And with that, we can reduce the dose to the patient, or we can optimize radiation dose to the patient in our Malaysian populations. I move to slide 39 now. We already are already, the time already 10 o'clock now. I'm going quite fast. Try to go very fast here. And this is the comparison between CT scan and PET. Yeah, PET using isotope, and they use gamma camera, and CT scan use detector and X-rays. Yeah, man-made radiations. Okay, and I'm go to slide 40. This is all the numbers of radiation dose from PET. Yeah. How much radiation? 30 microsievert per hour. Remember that isotope, they have a half value layer, not half value layer, half-life. Okay, half-life, how many hours? It will deduct into half of the dose, original dose. Yeah. Must remember that we have ALARA here. I put that something, I copied this from different presentations. Yeah, but ALARA, as low as reasonable, achievable, that's we try to use the dose for in practical way or as evidence based. Every people, 75% people practice with that radiation dose, then we have to practice that or below. Yeah, in this 50 millisievert per year is a annual limit for radiation workers. Yeah, so must remember that. And that's something that we have to try to memorize that things. So I think we're going to finish this. As a summary, I can say that effective dose measurement in PET-CT now available, and people now a little bit aware and knowledgeable about those radiation dose from CT scan. So this stuff must explain to the patients or what call it public about this issue. Yeah, CT component dose measurement we also discussed. If we use a X-ray tube, good X-ray tube, use detector, computer efficiency, high tech, and we can produce very good image in short time with quality so that we can reduce the dose to the patients. Yeah, and there is a numbers of method to measure dose in CT scan. And for your information that I really work quite close with my counterpart. He's a medical physicist at Semarang University there. The Diponegoro University, I think. That's why we publish a lot of articles using CT scan. Yeah, and he also developed two software to measure CT scan. Yeah, software. This is free. If we just members or email him, he can send you the link with where to download the software and how to use that. You can attend the course also. They can give you a course, but maybe summer course, something like that. But the explanation can be found from the YouTube. Yeah, he also got a brief explanation on the that software. Okay, I think I'm done with that. Thank you very much for your attention, for your time. I think that's a lot that I'm going already shared, but hopefully that you can digest it in short while. Okay, thank you very much. Back to
thank you,
Doctor.
Yeah, thank you, Prof. I think a lot of new things personally I learned from what you have been sharing for about 45 minutes. So, first, before I go further, anyone have a question? Maybe just unmute and then ask Prof. While if not, I will ask two questions. Anyone? Just don't worry, or you can type your question or just.
For sure, there is no exam, yeah.
Yeah, don't worry about that.
No exam, no quiz.
Just as what sembang-sembang kan, at least sembang with knowledge lah.
Can I ask question, Mr. Taram, Dr. Taram, and Prof?
Go ahead, please.
Yeah, I'm Yusuf. If I captured your presentation correctly, I heard as a layman term, you say CT scan dose compared to normal X-ray chest yang kita ambil dekat hospital is 150 times. Is correct?
Yes, you correct.
If correct, that means that the whole of my life, I'm above 60 years old now. Is less than 150 times I take X-ray chest. But if I take CT scan, meaning that if I take one CT scan X-ray, that means 150 times than normal X-ray. Is correct?
Yep, correct.
Okay. So my
the
question,
dose, yeah, the dose,
the
yeah,
dose, yes, correct.
radiation dose, yeah.
We're talking about radiation dose safety. Okay.
Hmm.
Question is, the dose is is to the patient or to the staff is for working is the CT scan.
See that staff, there's a few numbers of staff working when we have one examination. For example, we have nurse, we have porter like attendant, yeah. Nurse normally bring the patient in, and after that she going out. Radiographers position the patient, set the machine, everything, and radiographer also sitting outside. Okay, they communicate through intercom. Okay, and so only patient left there. So radiation totally for the patient. Yeah, the staff, they already stay outside unless we're doing extra other examination. For example, CT angio. For example, we try to study the brain with contrast injections. Now also we have an injector. Yeah, so we use the machine automatic. We set everything, then we go out unless they do a fluoroscopy CT scan. Now CT scan also use can do fluoroscopy, because the technology now very good. So in that case, radiologists must be there, yeah, or cardiologists must be there inside that CT scan room, and there, this guy, this personnel normally exposed to the radiation, but because the system, the CT scan itself, are very nice protected, quite equipped, or protection, they're quite good, and they use shielding. That's a principle of protections, and radiologists use all the equipment, thyroid, guard, the lead gown, everything, so that of course they're wearing a badge or radiation monitoring. From there, they're still safe. The radiation dose to the staff, even though next to the patient, still safe. Yeah, the reading not reach that limit, above the limit allowed by the international organizations. So
So,
I can say that
Prof,
that's safe.
sorry,
Sorry.
Prof. They mean
Yeah.
so my additional question.
Okay.
They mean the CT scan is not good for the patient then, unless it's the last choice. Can I make a simple statement like that?
When we talk radiation, talking about radiation, yes, but in medicine, there is no limit of radiation dose to the patients. And we must remember another point, that 3 point I mentioned. One is optimizations, knowledge. Another one is what? Can you remember that? One more. That's 3 here. Justifications. Slide 31. Justification means that how they justify. Let's say we have one disease for the patients. Other modality they try, but not. They also have a evidence base, and people practice that only CT scan can show that. Then we have to expose patient to the CT scan. For example, I give you example here. For brain brain image, the best to show that soft tissue is MRI. However, if somebody got accident and crack or the bleeding in the brain, they cannot go to the MRI because patient with the life equipment support, everything, gas, oxygen, everything there. So there's contraindication for the patient to go to MRI. Then they're opt to CT scan. That's what you said is if we really need that. So at this moment, we need CT scan to show how serious the patient's trauma or something affect the patient. So we have to choose CT scan. That we call it justification. And they have always talking about benefit and hazard. radiation hazard, quite weight, quite important, or patient life important, then they have to consider that thing. That we call it justification. For, let's say, female breast, something nodule or something, they want to see abnormal there, nodule or cancer, then they opt for ultrasound, no radiation at all, compared to CT scan. Now they have CT scan, breast, MRI breast. So MRI quite expensive actually. Then to answer your questions, this is how they justify the examination. Then they choose CT scan. If they have something options to do, then they just avoid CT scan. That's my answer.
Thank you, Prof. Thank you, Haji Yusof. Hopefully clear. Okay, I also have a few questions, Prof. Mungkin
Yeah, just
simple
answer.
one lah. Okay.
Still, just ask because we still got time.
Yeah. Any
not always.
I think you have answered one question in terms of research.
Okay.
Any research in place just to tell us that radiation workers kan, I mean especially yang jaga CT scan dan sebagainya, kata safe lah from, ada tak study yang mana mengatakan?
Ada, yes, ada. We just to search the articles yang related to that. In Malaysia, we have a numbers of expert, numbers of expert in CT scan. Yeah, for example, UNIZA, Dr. Kamarul, he expert in heart CT scan, and UKM we have a few. Dr. Prof. Akmal, he also. I think within last week, I saw that he produced one book of CT scan radiation dose. We can read that. I mean, there's a lately we got few scientists doing that. For the radiation dose to the staff, medical physicists normally do that. Ministry of Health, a lot of medical physicists, and we have numbers of scientists like UKM also have what is named Professor. I used to talk to them like in UM. Actually, my Prof. Eng, my co-supervisor, and another supervisor from Sydney University. So I got two supervisor from Sydney University. So I also communicate with him, and he did a lot of radiation, but not focus on CT scan. Somebody else focus on that.
Okay. Thank you for that. And apa ni yang the means mengatakan those kerja radiation menjaga CT scan, yang jaga apa ni kita punya ni
okay. This is a scientist issue, you know. There's something they find. This is something haven't done, you know. They're not studied yet. People not study yet, so they focus on that. They go one student. Okay, why don't you study this? Then they get all information and share the knowledge. That's good. But if you say that hazard, you see, we just have 0.06 millisievert for chest X-ray. Yeah, but annually we just far below from ALARA limit. Okay, 50 millisievert, 0.0. That's a lot, you know. So we are still in the safe side in the theory that we can say that stochastic and non-stochastic. If we just unlucky, the radiation just hit our gonad, something like that, and it's a mutation occurs, and we can have our children defect, you know.
That's one next question.
Yeah. So sometimes people give another analogy. You stand 50 meters from the paper or leaf on the field, okay. Then you try to blow that. Can you blow that paper, and the paper will go away or fly? Hardly to. So that's example of radiation dose to that, and to measure the
similar
cancer.
dengan noise exposure, ya.
Yeah.
Similar to the noise exposure lah. Maksudnya
Yeah.
there's a limit, yeah.
We try to blow something like radiation we expose, and we also got wind to blow the paper. So we cannot say that this radiation can cause, cancer there. So other factor also involved. So it's hard to tell that. Only they use figure to say something about that, And people never prove that, except Hiroshima and Nagasaki issue where the people got injured. And another one is those days when they use cathode ray tube for taking X-rays without protection, and radiologists got, industrial radiations. They got, a skin wound or something like that because too much radiation without protections. That's something that we just cannot compare with normal medical radiation, because all the system is quite nice and systematic. We monitor them quite well. Yeah, every department have the radiation officer to monitor that.
Understood. We have one question dekat chat box tu. Mungkin korang boleh baca.
Chat box.
Question,
okay.
Exposure to high radiation dose increase likelihood of cancer. My question is, will the CT scan, PET scan itself indirectly activate the cancer cell, especially to the patient?
Okay. There is a number of factors. Like I said, we now have automatic control of exposure factor. Smaller structure, we reduce the exposure. Like AP and lateral, okay? AP is quite thin. Lateral is a little bit thick. So when the X-ray tube move to one side laterally, they increase the exposure factor. When they move around to that part, reduce the exposure factor. When come to the chest, the breast, they reduce the radiation. So with that, we optimize. Yeah, the term is optimized. Now, when you talk about high radiation dose here, you compare with other structure. Yeah, but if you compare to the how safe the CT scan compared to the numbers of value that can produce cancer, is quite far, very, very far. Okay. I got one diagram actually to show that. I don't know where did I have one diagram from website, quite nice, to show how we can see that the hazard from radiation, medical examination is a very low end to the left, and cancer cause from the right. The gap is quite far, quite big. Yeah. Like I told you that if we just unlucky, the radiation hit that part and a mutation occurs, something like that. And another factor that I can say that female always got higher dose than male because they got more organ in their body. For example, in the abdomen, pelvis area. Yeah. So that woman normally calculated as a higher compared men. And another one is pediatric. Yeah. Because the body is still new, coordination of the cells not really organized, then we try to avoid pediatric newborn baby to CT scan. That's something that we can do to justify the examination. To answer your question again, I don't know, either it's directly or indirectly, I can say that. Okay. If you're not happy with me, you can study like CDC, America, yeah, Apansa, Australia, yeah. You just go to these two sites, then you can see Europe, another one, yeah, EU also produce a lot of document, yeah, but they can do is like good practice. They produce a book how to practice in proper way with CT scan. They got radiation article talking about this. I think the author that's quite famous, Borne, Boone, if I'm not mistaken. Yeah, McLeod, yeah, Mayo Clinic. She's working at Mayo Clinic. She produced a lot of article, books, everything about this cancer and radiations. If you want to see the protocol of the CT scan, you can go to CT is us. You just type CT, capital C, capital T, IS US. Yeah? CT is us. You can get a lot of information about how to deal CT scan machines. So that's a very technical information from that side.
Great. I think that's good. I hope if the answer is not complete as recommended by Prof, maybe you can have further information. But then, as I see that there is factors also that contribute to that lah. Of course, kalau you go direct to the private part, whatever it is, can cause, of course, mandul dan sebagainya lah. And cuma I think just to clarify, banyak study is happen in overseas and some in Malaysia lah.
Okay.
I read some of the documents recently, which is before this. Dia kata size of the person also influence the dosage, the effective dosage.
Yes.
So what is your comment on that?
Yes, that's correct. That's correct. Okay, let's say you have a patient age 20, let's say 20, yeah, adult. Okay, the size about 32 centimeter. Circumstances, yeah. Not circumstance, the circumference. Sorry, sometimes we use a different term. Circumference, yeah, 32. And let's say boy about 7 years old, quite small, yeah, 16, something like that. So 16 compared to 32, we have to increase the exposure factor for 32. If we use 16, then we have to reduce the dose. But in CT scan, the lowest dose that we can reduce, I mean the lowest kVp that we can use is 80. Why? Because we need the radiation dose pass through the subject, the object, to get detected by the detector. If not, we cannot calculate. You see the attenuations. If not, we cannot get the image nicely. That's why. Yeah. So the bigger the size, the dose increase. Remember, but we just compare this to the phantom. Yeah, not real patients.
So understood. Meaning that you mentioned tadi pasal effective radiation by human body maximum 15 millisievert per year, itu is considered as a normal people lah, bukan Asian size ke Caucasian ke, bukan
No, that one is a IAEA recommendations, yeah. Okay. International atomic, yeah. We also have if you want to read the report, this one is for global, yeah, global. There's another report, CT scan computer tomography report, yeah, by WHO. Division, I mean department from WHO. They produce the whole country in the world, include Malaysia, Indonesia, India, everywhere. So we can see that how they report it if we want to explore more. Yeah. That's something that we can get. In my thesis, I used that one reference from there also. That one year 2000. Now they have a latest version of a report.
Meaning that and then last question tu, maksudnya kalau kita buat X-ray, so it is how long that you can do the next X-ray? Kan nasihat saya 3 bulan ke macam mana?
Ah, there's something public always talk about this, isn't it?
Yeah.
I thought I already want to copy that information, but I forgot. I give you one link. It's very simple from YouTube. It's just explain something to public, what to do. You have to drink a lot of water. Means we have to improve our body immunizations. We have to dehydrate our body. Yeah, drink a lot of
Okay.
water. Do more
Okay.
physical activity. Then everything is easily diminished. Something that we can reduce the effect. But radiation dose is something, when they expose, they off it, there's no radiation, but the effect is on our body, and it takes some time if it's uh, really affect
Dia ada
the.
half life kan? Dia ada half life dia untuk dia
No,
dissipate
no,
jelas.
radiation, no. X-ray, like X-ray, CT scan, general radiography, once they off, nothing, done.
Yeah.
Except our body, if there is something effect, then the cell die or something like that. But very low radiation, we won't get that.
Okay. So nothing to worry about half life of that kan?
No, don't worry about that. Today X-ray, in the afternoon 5 o'clock, you can kick the ball on the field.
Yeah.
Or go to gym. Don't worry, because we are radiographers. Actually, we work in the room, and that's another hazard, ozone, because the spark there, So we have to go out and do physical, go for jogging, then get fresh air. That's it.
So
All done.
administrative control tu dia kena stop sekejap, keluar, get some better environment lah
Not immediately, but we suggest, encourage to go to open space, open the window at our home, don't use a lot of aircon, something like that.
Okay. So I think kita 10:30 already. Anyone have any last question from the audience? Kalau tak ada, I think kita boleh conclude lah kot hari ni. So tak ada So
boleh saya
go ahead. So
ini Prof, ini offset sikit question, tapi
okay. Nanti sebelum you tanya, Yusof,
ada related to safety.
Nanti Yusof, sebelum you tanya, I just want to know where you from.
Oh, saya di Kuantan.
Oh, that. Itulah.
Orang lama.
Okay.
Okay. Sekarang ni sebagai comparison, Professor, saya dealing a lot of people with perform NDT.
Okay, non-detect.
Yeah,
non-detecting
test. Dia testing tebalan pipe dan sebagainya. So they involve a lot with the dose of radiation lah. So kadang-kadang kita buat NDT, dia barricade. Ada yang 40 meters, ada yang 50 meters tak boleh masuk, gitulah. Jadi my question is, saya tengok tadi sebentar lalu tak ingat, CT scan punya dose of radiation is one of the highest in medical punya term lah, compared with chest
in the medical examinations.
Yeah, medical examination. So ada side effect there lah, whether you like it or not. So my question is, kalau compare dengan people who perform NDT, dia kerja every kalau musim tu every night tu kadang-kadang dia kerja non-stop for 2 weeks or 1 week. So ada tak study sebagai comparison, ada study tak menunjukkan people who perform the NDT yang orang public tak boleh masuk 40 meters, 50 meters radius compare dengan scan punya radiation dose?
Itu soalan dia
Ya.
Okay. Nombor satu sekali, biar sebelum saya pergi kepada NDT, saya pergi kepada CT scan dulu. CT scan really safe in term of protocol, everything, very systematic. So that's why we can control that. So there's no issue about safety in CT scan, except the radiation that exposed to the patients. However, still under control. Compared to NDT, sebelum I pergi tu, I pun sementara saya search artikel, saya banyak juga dapat NDT punya artikel and website. So saya nak tanya satu, adakah dia gunakan apa nama tu, radioisotop ataupun X-ray radiation source? Cik Yusof.
Sorry Prof, apa question?
Question dia, dalam NDT ni dia gunakan radioisotop ataupun gunakan X-ray radiation source? X-ray.
From my experience, they use both.
Both
Both.
So macam mana dia gunakan portable X-ray machine kan?
Betul.
What I understand, bila dia pakai, bila NDT measuring the ketebalan pipe dan sebagainya, saya nampak dia macam ada, dia masuk dalam store, ada source of radiation.
Source tu macam mana?
Dia tembak aja pakai isotop, begitulah yang saya faham lah.
Itu
Tapi
tadi
yang saya tahu dia pakai both method.
Tapi kalau you kata isotop is different, okay? If you want to deal the isotope, radioisotope with X-ray different. X-ray, when we press the button, it's X-ray on. When we release the button, it's off. We normally set the time, let's say 0. Paling lama lah X-ray dalam fluoroskopi. Kalau nak paling senang sekali nak bagi contoh, bila kita pergi dentist, ya, jumpa dentist, dia ada X-ray, dia panggil OPG. Dia scan semua muka kita, gigi kita gunakan satu X-ray, satu kali expose dalam 2 minit. Dia expose daripada kiri ke kanan. Itu 2 minit, tapi dia guna radiation dose yang rendah. Tapi dalam ini, kalau tadi dia guna X-ray, dia bawa tube, pipe tadi masuk dalam tu, dia expose, dia patutnya tak boleh berada kat situ semasa dia expose. Dia akan keluar. Kecuali dia perlu bergerakkan benda tu. Tapi bila nak gerakkan tu, dia kena gunakan protection semua cukup. Kalau tidak, tu salah dari segi praktikalnya. Itu kalau gunakan X-ray machine. Tapi kalau katakan tadi radioisotop, more dangerous because number one, we cannot see that. We cannot feel that. Cuma kita gunakan detector, X-ray detector and reader there. Then totally the radioisotope we cannot control unless we close it with the appropriate proper lid, for example. Tapi kita mesti guna glove dan juga protector kita, lead gown. Kita mesti tutup dia dan dia ada half life. You guna isotop apa, for example, then half life dia berapa? It's still on until quite some time because exponent, the radiation from isotope still there. So we have to very careful and handle that in proper way. Kita tak boleh jenis orang-orang yang leceh-leceh yang suka sepa-sepa. Kita mesti orang yang cermat bila deal dengan isotop ni. Sebab tu orang yang pergi nuclear medicine punya department, they are very particular. Cermat punya orang kerja. Tak boleh tumpah-tumpah air tangan basuh selalu. Dia proper protect badan dia. Itulah yang saya boleh cakap. Jadi jawab soalan you ke tidak, saya kurang pasti dah tadi. You compare CT scan dengan tadi industrial NDT kan. Kalau dia banyak radioisotop, then you nampak tak tadi saya compare PET dengan CT scan, almost cuma rendah sikit je dia punya dose dia. So tapi beza dia, that dose bila kita check kat patient, dia balik rumah pun dia masih ada radiation tau. Dia tak boleh pergi jumpa kawan dia, pergi minum kopi kat sana kat sini because radiation masih ada lagi. Kena minum air banyak, keluarkan daripada urine dia semua, kencing banyak apa semua kan. Feces dia pun ada radiation. Ini yang kita nak ceritakan dari segi isotop. Quite dangerous, we have to learn more on that.
Okay. So I think so you saw tadi more on any research or study on that part lah kot. Maybe we
banyak.
We dig further on that. I believe there is. Cuma kita tak jumpa yang is more very orang kata highly technical punya research kan, mungkin specifically an exposure on occupational radiation tu mungkin banyak lah. Tapi tak apa, I think we can look into that. But terima kasih banyak-banyak Prof kerana meluangkan masa pada malam ni untuk kongsi ilmu. I think banyak ilmu yang saya personally belajar dan sebelum ni saya tak tahu, sekarang saya tahu sikit. So dan terima kasih kepada semualah, terutamanya Yusuf dan siapa-siapa yang ada tanya soalan dalam ni, Puan Razila, Ros Haliza, Puan Emilia dan siapa-siapa yang tanya soalan dalam ni lah. Saya apa ni, terima kasih banyak-banyak. So last word daripada Prof sebelum kita adjourn from this bual bicara.
Okeylah, tu yang saya juga mengucapkan terima kasih lah kerana memberi peluang saya. Saya tak kata menjemput, memberi peluang kepada saya untuk berkongsi ilmu. Saya rasa ilmu ni untuk dikongsi lah. Walaupun saya tak banyak publication, but kadang-kadang kita publication ni orang-orang yang saintis yang bacanya, yang orang public ni tak banyak baca, dia dengar cerita je, kadang-kadang wrong information. So kalau boleh kita lebihkan keadaan ini, dah bagus lah aktiviti yang ini. Jadi saya pun sebahagian daripada sekali dalam berapa banyak yang you dah buat, saya mengucapkan terima kasih juga dapat peluang ini. Semoga kita ilmu yang ada ni kita dapat berdekatkan dia, kita amalkan dia, kongsi dengan orang lain, jadi kita sama-sama mendapat manfaat daripada dia.
InsyaAllah. Saya dapat manfaat daripada insyaAllah. Apa ni mungkin lain kali exactly boleh jemput lagi Prof untuk zoom out certain particular, sekarang ni more generic mungkin.
General sangat untuk CT scan.
Based on question tadi kan, yang mana kita still struggle dalam industri untuk get the answer correctly lah. So based on the myth, based on here and there, say macam Prof kata tadi lah kan. So itu yang bahaya tu.
Itu yang kita jadi takut nak buat kerja apa, tapi kadang-kadang benda yang betul-betul serious, danger tu kita pula not aware about that.
Okay. So dengan itu saya sudahi dengan
terima kasih semua.
Assalamualaikum warahmatullahi wabarakatuh. Terima kasih Prof. Jumpa lagi insyaAllah. Terima kasih semua kerana join dan terima kasih atas soalan-soalan semua. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.